Hallelujah.
All right.
We're good to go? All right, thank you. Go, Joe.
All right. Good afternoon, everyone,
Afternoon.
and welcome to our session, Know Your Numbers. So, as we get ready to start, we will have a time of devotion. That's a time of praise. So I just ask for you to just stand with us as we sing choruses unto God.
Amen.
So we will start with God is a good God.
Yes, He is.
God is a good God. Yes, He is. God is a good God. Yes, He is. God is a good God. Yes, He is. God is a good God. Yes, He is. God is a good God. Yes, He is. He picks me up. He turns me around. He plants my feet on higher ground. He picks me up. He turns me around. He plants my feet on higher ground. He is a miracle working God. He is a miracle working God. He is a wonder. He is a miracle. He is a miracle working God. He never fails me yet. He never fails me yet. Jesus Christ never fails me yet. Oh, everywhere I go, I want the world to know Jesus Christ never fails me yet. He never fails me yet. He never fails me yet. Jesus Christ never fails me yet. For everywhere I go, I want the world to know Jesus Christ never fails me yet. Daniel's God surely will deliver. Daniel's God surely will deliver. If you only look to Him by faith, Daniel's God surely will deliver. Everybody ought to know.
Oh, yes.
Everybody ought to know. Everybody ought to know who Jesus is. Everybody ought to know. Everybody ought to know. Everybody ought to know.
Everybody ought to know
who Jesus is. Jesus is the lily of the valley. He's the brightest morning star. He's the fairest of 10,000s. Everybody ought to know.
Hallelujah.
And we will just just have one final song. Lord, prepare me to be a sanctuary. Lord, prepare me to be a sanctuary, pure and holy, tried and true, with thanksgiving. I'll be a living sanctuary for you. One more time. Oh Lord, prepare me to be a sanctuary, pure and holy, tried and true, with thanksgiving. I'll be a living sanctuary for you. Hallelujah.
Hallelujah.
So, evening, ladies and gentlemen. As we begin this seminar, we want to start with a reflection on Jabez's prayer. And we have labeled this Jabez Reset. And if many of us, I just remind you the prayer in 1 Chronicles 4, verse 9 to 10. It says, Jabez was more honorable than his brothers, and his mother named him Jabez, saying, because I gave birth to him in pain. And watch the two words, in pain. Now Jabez called on the God of Israel, saying, oh, that you would greatly bless me and extend my border, and that your hand might be with me, and that you would keep me from harm, so that it would not hurt me. And God brought about what he requested. 1 Chronicles 4, verse 9 and 10. We're going to have a video now that just captures what I believe is the spirit of Jabez's prayer in light of today's situations and struggles for people like us, looking like us, coming from the global south and facing the challenges that we face. We just ask our control room just to open the video for us, please.
They're away first time. Can Shelley-Ann Fraser-Price deliver? She's got a good start, but watch Sharika Jackson. Sharika Jackson, is she just going to do it? Oh, on the near side, right at the end. They were getting ready from nowhere in lane 9. It's an incredible performance from Sha'Carri Richardson. Richardson came through.
One of the most recent blockbuster bestsellers has been The Prayer of Jabez, breaking through to the blessed life, Wilkerson, 2000. However, the fault lines of Wilkerson's fictional personality has been traced to the 14th century with the introduction of the letter J, which was never in the alphabet before the 14th century, into the lexicon. In other words, the Jabez personality to whom the prayer is attributed is underlined by fraudulence. Yes. False documentation. Moen 2021. Now, I want to just look at this through 3 particular movements. One, I call decolonizing the myth. of the prayer of Jabez, as told to us outside of the framework of reading the Hebrew text to understand exactly what the Hebrew text says, decolonizing the myth. Secondly, what I call realigning the truth, the meaning of the name. And thirdly, what I would want to see as leveraging the health challenge to a post-slavery population with top-end speed breakthroughs. So I think for most of us, what we saw there just a while ago captures two things. An extraordinary athlete who has a major problem in terms of her start, and also has possibly the best top-end speed among female athlete sprinters in the world. Two things held together. Wilkerson's book speaks about a miraculous breakthrough. But what we are talking about is not a breakthrough, but accepting the reality of what we have as a weakness and using our strength that has been given to us as the benchmark, as a means of improving on the weakness that we have. In other words, if we read the prayer of Jabez, you will notice that the word used to bless also speaks of the same idea of being in pain, and it also speaks to the same idea of being in need. Jabez was born in pain, and when his mother did it, it wasn't because she was someone who was obviously dysfunctional, but that was the thing of the time. If you remember the situation with Benjamin and Rachel, what happened when she had Benjamin, because she suffered significant pain in childbirth. The name itself was a representation of her existential, her experience, her reality. So I want to put that in the context of this particular meditation that we have. One, in terms of decolonizing, is to understand, one, the issue of the fact that we cannot take our advantages that God has given us without looking at the disadvantages that we might be born with. And don't be concerned about carrying them with us, because what God has done for us is given us the strength as a means of countering our weaknesses, as we see in the case of Shakari and we see in the case of Jabez. So what we hear when he says in pain, the same word in terms of the regular translation, in terms of the intensive form, is the same word that talks about extreme brilliance. Indeed. So indeed means God blessing us tremendously at a certain point in order to make sure that the disadvantages are offset by our advantages. So W.B. Du Bois, as most of us know, had the concept of double consciousness. And that's the kind of double consciousness we're talking about. A double consciousness where he said we see ourselves through the eyes of our colonial benefactor. And we see ourselves through the eyes of lived experience as people who have suffered slavery and etc., etc. So we are double conscious people. And being double conscious is not a problem. It's not a harangue. It's not something that we fear to carry, because we know the God who challenged us with our challenges is also the God who gives us our opportunities, our strengths, that we may be able to succeed over the challenges as we saw there. So we speak about the situation of decolonization. And 2 Corinthians, 1 Corinthians, I think, 13, it says that now we see in a dark glass, but then what? We see as we are seen. And for many of us, we may take it to relate to a future by and by. But I want to tell us it has to do with our reset, rethinking about ourselves, reassessing ourselves in terms of who we really are as individuals, born with a set of circumstances, fooled to think that we are somebody else, fooled to think that when there's a challenge, the first thing we should ask for is a visa to try to escape the challenge. Fooled to think that maybe when situations become hard, and as understood as it may be, feeling that we need to take flights, whether as athletes or whatever it is, to move to somewhere else for greener pasture. No disrespect for persons who do it, but just to say to us, there is a reality that we must come to terms with in terms of who we are. We cannot forget that. So we talk about decolonizing that self, recognizing our weaknesses with our strengths. But we speak about a realignment. And that realignment, as we said, has to do with the fact that the same word, barak, stands for in pain, stands for the intensive form which says indeed. It is not separated. And we have to realign ourselves to understand, as I said, that we carry this yoke as well as this tremendous gift together. The word is used. We are hybrid people. And hybridity is a part of who we are. Born in pain, born in challenge, born in circumstances beyond our own expectation. But being forced to carry this reality and realizing to ourselves that it is something that we should carry proudly. It is not something that we should defer. It is not something like the child that is born in a certain way and we disown it and place it in a home in order that we do not identify with him or her. That is not God's plan, because God's plan is redemption of all humankind. So we speak about decolonization, we speak about realignment, but lastly, we speak about leveraging the health challenge to a post-slavery population with top-end speed breakthroughs like what we saw there with Shakari. And I want to bring a kind of quick SWOT analysis to our attention. One, the strengths. Addressing hypertension, we have the Caribbean South American team-based strategy to control hypertension. CATCH is the acronym. Addressing the challenge in digital health management, Caribbean Public Health Agency, CPHA. That is the acronym. Addressing mental health, allegory, like allegory, allegorically speaking in terms of metaphor. And what we see here, the company, right? What we see here, as we said, is a company that focuses the application of neuroscience to address mental health challenges and the stigma, offering innovative business models. What are our weaknesses as a people as we begin to reset, just like Jabez? Deficiency in genomic surveillance to enhance probability of early detection of diseases. That is one of our weaknesses. Not recognizing and rewarding a philosophy of development that understands that one's knowledge is not isolable or separable from the generosity of the society that made it possible for one to be so endowed in the first instance, and in whose service it must be deployed if knowledge is to be meaningful. Opportunities. The National Health Fund, NHF, can emulate the National Housing Trust NHT by focusing on strategic partnerships, cost-effective procurement, and efficient service delivery to reduce healthcare. This would improve pooling resources, leveraging bulk, and purchasing power. Lastly, what about our threats? Inhibitive health costs associated with privatization of healthcare due to the challenges of the American society influence on us and the rise of social Darwinism. In summary, in a context of potential reemergence of social Darwinism in 225, the prior of Jabez offers lessons in faith, humility, and the pursuit of purpose beyond self-interest. Jabez's prior focuses on divine blessing and protection, highlights the importance of seeking God's will and influence rather than solely individual gain, which contrasts with the competitive and hierarchical worldview of social Darwinism, which is on us. Thank you very much. We're going to ask Mr. Joel Batty to, at this time, introduce our chairperson.
Good evening, everyone. I've been given the honor to introduce our chairperson for this evening. So, Dr. Caitlin Beecher is board certified by the Canadian Board of Endodontics and is currently going through the process to be boarded by the American Board of Endodontics. She graduated from the University of Technology Dental School and did her postgraduate specialty training at the University of Toronto Dental School. Dr. Beecher is a compassionate and skilled endodontist and practices the full scope of surgical endodontics here at Emirates Facial and Dental Implant Center. Shall we welcome Dr. Caitlin Williams Beecher.
Good afternoon, everyone. It is my pleasure to be here with you all, and just for those of you who may not be familiar with the term endodontist, I'm a dentist that focuses on root canal treatments. But it's not about me today, it is about you guys and learning about knowing your numbers. And to get us into that, we have Professor Dr. William Bill Akin. He's currently on call, so I'm doing this very quickly so that he has an emergency, actually. So we're getting him on stage right now so he can speak to you, so he can get to his patient and do what he does best, which is being a urologist. He earned his bachelor's degree from the university, his MBBS, and became the first graduate of UWI's Doctor of Medicine in Urology program in 1998. So he's been doing this a while. So you know the boss, he has that information to get to us today. So he's currently a professor and consultant urologist in the Department of Surgery, Radiology, and Anesthesia and Intensive Care at the University Hospital of the West Indies, who paged him not too long ago. His scholarly output includes over 50 peer-reviewed publications, 79 academic papers listed on ResearchGate, and leadership roles as president of the Jamaica Urology Society, Caribbean Urology Association, and the Association of Surgeons in Jamaica. So you can see that this is a gentleman that is well-researched and well-informed. And as such, he's also a family man who has 6 children with his lovely wife, Ella. And at this time, we are going to welcome Dr. Akin to come and speak to us.
Thank you, Dr. Beecher, for that warm introduction. And let me, first of all, thank you for inviting me to be here with you this afternoon. It is a pleasure to be here. This church holds very special significance to me Well, first of all, I'm a member of the United Church. I worship at Webster Memorial United Church. But years ago, we typically came to this church for watch night service. We would always come here, my family and I would come here for watch night service. And Gary Carr, I don't know if Gary is still here, Gary Carr would typically take the service. But also, I got married right here on the 29th of July 2009 on a Wednesday morning. So this church holds very special significance to me. And my wife went to Meadowbrook High School. So you see, there are lots of connections. And this is not my first time doing this talk here. I've been here before to give health talks. So I'm very happy to be here. I am a little challenged, though, in that as soon as I drove in, my resident, I'm actually on call for the hospital. And as soon as I drove in, my resident called me to say they have a patient who is bleeding, who is taken to the operating theater. So I told him if he needs me, call me. But if he doesn't absolutely need me, I am giving a talk. And so if I get a call to go, unfortunately, I must go because it's a patient's life we're dealing with. So I was asked this afternoon to talk about men's health. And men's health is a very big subject because in Jamaica, our men are challenged by a number of health issues, one of which I happen to deal with on a regular basis, and that is prostate cancer. And some of you may know, or all of you may know, that prostate cancer is the #1 cause of cancer deaths in not only in Jamaica, but in many parts of the Caribbean. Wherever you have Afro-Caribbean men in large numbers, prostate cancer is a highly prevalent condition. It is a leading cause of cancer and the leading cause of cancer deaths in Jamaica. So it's the #1 cause. #2 is breast cancer in women, and #3 is colorectal cancer, which is increasing in incidence. So I don't only want to focus on prostate cancer, though, because men's health involves a lot more than prostate cancer. Health is not merely the absence of the disease, but it's a complete physical, mental, social, and indeed spiritual well-being. Of course, given that definition, there are very few of us who at any one time will enjoy totally good health. But that is what we aim for, a complete state of physical, mental, social, and indeed spiritual well-being. So when we look at health, we're not only looking at the physical man, we're also looking at the emotional and mental aspects of the man. We're looking at the social aspects, and we're in church, so we recognize, and science is indeed recognizing how important the spiritual aspects are to the well-being of persons. We know that persons who pray regularly and so on enjoy better health, and persons who are ill, the science has shown that when you do randomized controlled trials for persons who pray versus those who don't, the persons who pray seem to have better outcomes. So we know that the spiritual aspects of well-being are very important. But I want to start off by saying that our state of health at any point in time is determined by a multiplicity of factors, some of which are beyond our control and some of which are within our control. Outside of our control is the genetic deck of cards we've been dealt with. Elder who was up here earlier spoke about genomics, and genomics is a big thing in medicine now, where we look at the genetic risk factors. Well, when we are born, we inherit a genetic deck of cards which determines what are those diseases that we may potentially suffer from at some point in our lives. And we have no control over that. We have no control over who our parents are or what we inherit from them. And because the genetic deck of cards we inherit may put us at risk for certain diseases, the first point I want to make is that where possible, it is very important for you to know what diseases run in your family. Because it is very likely that if your parents or your siblings suffer from a particular condition, that you may be at increased risk of that condition. Now, I know in many instances in Jamaica and Caribbean life, men in particular may not know who their fathers are. I work at the Cancer Society on a monthly basis. I do free prostate cancer screening there. And you'd be surprised the number of times when we ask men about their family history on their father's side, and they can't tell us because they just don't know who their fathers are. They never grew up with them. They don't know what their family history on that side is. But wherever it is possible, it is important for persons, not just men, but everybody, to know your family history. Because if you know your family history, it tells you what your susceptibilities are to particular illnesses, and it may alter the screening schedule for you. So let me give you an example. If, for example, you have a father or a mother or a sibling who had colon cancer, the current guideline is that you should start screening for colon cancer at age 45. However, if you have a parent or a sibling who has colon cancer, you should start screening for colon cancer 10 years prior to when they were diagnosed, or age 45, whichever one comes earlier. So for example, if your sibling got colon cancer at age 50, then you should start screening at age 40 and not age 45. So that's just one example to show you how important it is to know what diseases there are in your family, which you have no control over, and how it can affect what you do in terms of screening. It can also cause you to place greater emphasis, not just on screening, which is a secondary form of prevention, but for example, if you know that there is a strong family history of hypertension or high blood pressure in your family, then from early on you can make sure that all the lifestyle changes that you need to make to prevent the onset of hypertension, you start doing early. So you pay careful attention to your diet, so you know that you don't consume a lot of salt in your diet. Rather, you consume a lot of different colored fruits and vegetables and potassium-rich foods. You make sure that you exercise regularly, so you engage in regular physical activity. You ensure that you keep your body weight within the normal range. You ensure that if your job is a stressful one, that you make opportunities to de-stress on a regular basis. You make sure that you do not smoke or drink alcohol in excessive quantities. So these are some of the things that you can proactively do when you know you have a particular family history of a condition. So that's the first thing I want to make. Know your family history. The second point I want to make is that whatever our state of health now, apart from being dependent on our genetic deck of cards, potentially, it is also dependent on the lifestyle choices that we have made in the past. Or, another way to put it, whatever state of health we will be in the future, 10, 15, 20 years from now, will be dependent on the lifestyle choices that we make today. And what are those lifestyle choices. Some of them I just alluded to, and some of them are well known, but I will still mention them. So it is clear that we need to avoid any kind of smoking, right? That is clear. The science is very clear on that. Smoking increases your mortality. It causes early death from a number of different diseases. It affects every system in the body adversely. But data is now coming out that any alcohol, any quantity of alcohol is not good for you. It used to be the dictum or the dogma used to be a little red wine or a little alcohol is good for you. And it used to be said that, you know, having some red wine there was a J-shaped curve in terms of mortality and alcohol intake. A little alcohol is good for you, but as you increase the alcohol intake, it then becomes bad for you. But as more and more scientific evidence accrues, we now know that alcohol is indeed a toxin, and that really no alcohol is good for you. and so that is something that you need to take into consideration. You need to decide whether you're going to drink any alcohol at all. What we can say for sure is that binge drinking is out. So you should never drink alcohol in excessive amounts. But the science is now suggesting that you shouldn't drink any alcohol at all. All right, so that's the other thing that I want to leave with you. And then your diet. We are to a large extent what we eat. And again, many of you know this. What we put into our bodies to a large extent determines the health of our bodies. If you put junk in, then you are setting up yourself to have a lot of diseases taking place. We know that things like red meat, animal fat, processed meats like bacon and sausage and salami, we know that processed foods in general are not good for you. So these are some of the things that when it comes to your diet, you should eat sparingly. So red meat, animal fat, processed meats are, generally speaking, not good for you. What about sugar? Yes, sugar. Sugar is, the evidence is, again, increasing that sugar is not, sure, thank you. Sugar is not something that you should take in excessive amounts. And you should limit your sugar intake. So sugar, salt, and fat, animal fat in particular. There are some types of fat that are actually good for you. So fat that are associated with certain fish, like salmon and mackerel and sardines, those types of fats actually are good for you, and they are rich in what are called omega-3 fatty acids, and they're good for your circulation and so on. But the type of fat that you get, like on the chicken skin, you know, when you go to KFC and all the taste in the KFC is in the skin of the chicken, that is exceedingly unhealthy. But that's where the taste of the chicken is. But when you consume that on a regular basis, you are setting yourself up for disease. The fat that you get in the pork, that kind of fat again, that animal fat and the beef fat, all of those types of fat are not good for you. So generally speaking, you should be limiting your intake of red meat and animal fat. You should be limiting your intake or eliminating altogether processed meats in the diet. As adults, especially adult men, you should also limit your intake of dairy products. Yes, dairy products. You heard right. So milk, butter, cheese, ice cream. These things, I'm not saying you can't eat them, but you should definitely limit your intake of them because they are associated with increased risk of prostate cancer and indeed other cancers. Physical activity. Again, you would have heard this over and over. physical inactivity is a big killer. When you remain sedentary for long periods, it creates a certain metabolic environment in your body that increases the risk of things like diabetes and pro-inflammatory conditions that adversely affects your blood vessels and your pancreas and so on. So not moving is not good for you. It is recommended that you should exercise for at least half an hour on a daily basis, whether it's through brisk walking, whether it's through skipping, whether it's through jogging, swimming, bicycling. It really doesn't matter, but you should get moving. You should move your body for a minimum of half an hour each day. And the science, again, is very clear. Physical activity is very good for you. It prolongs your life. What about adequate sleep? I know there are some people who get very little sleep at night. But again, the evidence is clear. If you are chronically sleep deprived, that is, if you go many for long periods without adequate and sufficient sleep, you are more likely to have a premature death. Sleep is very important, and good quality sleep as well, not just sleep in terms of quantitative sleep, but quality sleep is important, because it is during good quality sleep that the body heals itself and the cells regenerate and a lot of healing takes place. So if you're not getting enough good quality sleep, then your body is not getting a chance to regenerate itself and heal. And you will die a premature death because of insufficient sleep. So sleep is very, very important. Then there are other things that we need to talk about, like maintaining a normal body weight. Obesity is associated with 11 cancers. 11 cancers. And of course, obesity is associated with things like diabetes mellitus. It is associated with erectile dysfunction. It is associated with a reduced libido. So obesity affects persons, and particularly men, in adverse ways. When you have a big tummy, it converts the male hormone testosterone into the female hormone. And so men with a big tummy may say that their breasts get bigger, and that increased estrogen in the men's body shuts down their interest and desire for sex, and it adversely affects your erection. So having a big gut or a big tummy is not good, and generally being obese is, as I said, associated with 11 different cancers and increases your risk of premature death. There are some other things. We have a dentist in the house, and the scientific evidence, while not absolutely conclusive, suggests that there is a significant association between your oral health and your cardiovascular health and even your erectile function health. We know that there are some studies that suggest if you have a lot of plaque buildup and you don't go to the dentist and clean your teeth on a regular basis, your risk of cardiovascular disease is increased. And because the blood vessels to the penis are some of the tiniest blood vessels in the body, generally when men are suffering from poor circulation, one of the first places it shows up is in your ability to get a hard erection. And so this evidence suggests that men who don't maintain good oral hygiene by visiting their dentist regularly and making sure they have their teeth cleaned and paying attention to their oral health by flossing and brushing daily, that it may adversely affect your sexual health, but more importantly, it may affect your cardiovascular health and your longevity. I've even seen some studies suggesting an association between oral health and the development of Alzheimer's disease. But I think those are preliminary studies, and maybe we need more studies to look at the association. So these are some of the important things that men need to do. But there are other things. In Jamaica, the things that greatly affect our population: obesity, hypertension, diabetes. You could do all the things that are necessary to prevent yourself from developing these problems, but they may still happen. And so I say to men, from the moment you reach the age of 35, you should go to your doctor on a regular basis and have a checkup to ensure that your blood pressure is checked, your blood sugar is checked, your cholesterol levels are checked, because these are things that are of high prevalence in our society. And if you become diabetic and you don't know, the diabetes there is adversely affecting every system in the body and you're not aware of it. Whereas if you become aware of it through attending your doctor and screening, then at least you can put corrective measures in place. Same thing with hypertension. Hypertension and diabetes are the two most common causes of kidney failure in Jamaica. Kidney failure is very common, and those are the two diseases that will destroy your kidney. They will also destroy your eyesight. So these are some of the things, because diabetes and hypertension affects every system in the body in a bad way. And they are called the silent killers, because you may not necessarily have symptoms that suggest that you have these. And this is why it's important. From the moment a man reaches the age of 35, you should have your regular checkups on an annual basis to ensure that all of these things are screened for. So those are some general comments that I want to make before specifically talking about prostate cancer. Because, as I said earlier, prostate cancer is a major killer of our men. And I want us to focus on that for a little while. So we said earlier that prostate cancer is the most common cancer affecting men, but it is also the most common cause of cancer deaths among all cancers, affecting both men and women. It's the #1 cause of cancer deaths in many Caribbean countries. And the reason the death from prostate cancer is so high is that men do not have the culture of going to their doctor to be screened on a regular basis. Exactly what I just spoke about. Prostate cancer is one of these diseases that when it is early, it doesn't cause any symptoms whatsoever. It is only when it becomes advanced and has metastasized or spread that you start getting symptoms. So a man will be there thinking he's perfectly healthy and well and fine, and will be going along his business thinking he's perfectly well, while there's a cancer growing inside of him that the only way he would know is if he goes to the doctor and does the necessary tests. But because our Jamaican and Caribbean men don't go to the doctor routinely to be tested and wait until they have symptoms, by the time they come to us, the disease, prostate cancer, is advanced or it has metastasized, and we can no longer cure them. We can only control the disease for a period of time. So this is one reason why the mortality or the death rate from prostate cancer is so high in our populations. So one take-home message today is that once a man reaches the age of 40 years of age, he should go to the doctor every year and have his prostate checked. And having your prostate checked essentially means having 2 tests done. A blood test called your prostate-specific antigen blood test, which is a simple blood test, and the other test, which we know men don't like to do, and that's a digital rectal examination where the doctor puts his or her gloved and lubricated finger in the rectum to feel the prostate and to determine whether it may be suffering from disease or not. The normal prostate feels like the tip of your nose. If you feel the tip of your nose, you'll feel a firm rubbery consistency. When the prostate has cancer in it that we can feel, it feels like my knuckle. It is hard. So that is what we're looking for, among other things, when we examine the prostate. And the truth is, done by a urologist, the test takes about 10 seconds or less because we know exactly what we're looking for. And it's a test that could easily save your life. So I encourage men 40 and above to do both a blood test and the digital rectal exam. If either of those is abnormal or both are abnormal, we then go on to do a biopsy, which is taking a pinch of tissue from the living body, in this case the prostate, to send to the pathologist to have the tissue diagnosed, looked at under the microscope to make a diagnosis. Prior to doing the biopsy, we'll do what is called an MRI, a multiparametric MRI, magnetic resonance imaging, which is just a special imaging test using powerful magnets that creates an image of the body. And the multiparametric means that it's both giving us anatomical information as well as functional information that tells us whether there is likely to be a cancer present or not. And we have a grading system that tells us so. So doing the MRI before allows us to target a specific area and increases the yield of the biopsy. So those are important tests that should be done starting at age 40. That is the blood test, the PSA, prostate-specific antigen blood test, as well as the rectal exam. Now, some of you may ask, you know, what is the prostate gland exactly, and what does it do, and why does it give so much trouble? If I could have the next slide. Right, and the next slide. Right, so the prostate gland is what we call an accessory organ of male reproduction. The primary organs are the penis, which is an organ of copulation or sexual intercourse, and the testis, which produces the spermatozoa to fertilize the female egg. But there are some other supporting organs like the prostate that play a role in male reproduction. So when a man ejaculates, 20% of the secretions in the semen comes from the prostate. And those secretions have nutritive substances in it that gives energy to the spermatozoa, a lot of sugars. It has anti-infective agents in it that are rich in zinc. It has antibodies. And very importantly, it has prostate-specific antigen, the same prostate-specific antigen that we check for in the blood. And this prostate-specific antigen keeps the semen in a liquid state so that it flows freely in the female genital tract. So that's the role that the prostate plays. Where is it located? It's located, if you show me the next slide. Next slide, please. You will see just below the bladder, and unfortunately I don't have a pointer, I apologize, but that organ that is sandwiched between the pubic bone in front, right at the base of the penis, and the rectum behind. That's the bladder on top, and immediately below it you see the prostate gland. And you'll notice that the urine passage passes right through the middle of the prostate and is met by the ejaculatory duct within the prostate. That is where the semen, some of the semen comes from. So when the prostate gland becomes enlarged, it tends to pinch off the urine passage and cause symptoms. And when this happens, the patient starts having symptoms such as getting up often at night to pass urine, or they may find that they're going often during the day because they're not emptying their bladder. They may find that they don't have enough warning because the bladder becomes overactive, so they develop what is called urgency. They may find that When they go to pass urine, it takes a long time for the urine to flow, and it becomes weak. The urine starts to dribble, and they may find that when they finish passing urine, they feel like urine is left behind. Now, these symptoms are not necessarily symptoms of prostate cancer. Thank you. There can be symptoms of prostate cancer if the cancer is advanced. But there are two other conditions that affect the prostate that cause the prostate gland to enlarge, and enlarge immediately around the urine passage. And one of these conditions is called benign prostatic hyperplasia, or BPH. And all men, as they get older, will develop BPH, or enlargement of the prostate gland. Fortunately, not all men will necessarily become symptomatic from enlargement of the prostate gland. But when they do, the symptoms that I mentioned earlier, the getting up at night, not able to hold the urine, the dribbling of the urine, and feeling like you're not emptying the bladder well. And sometimes these men develop what we call stoppage of water, or acute urinary retention, or sometimes they develop chronic retention of urine and kidney failure, because urine, they're not emptying the bladder as well, and the urine backs up right back to the kidneys. These are all possible effects of an enlarged prostate, either from BPH or from prostate cancer. But as I said, if prostate cancer causes these symptoms, it usually means the cancer is advanced. So that is where the prostate gland is located, and you'll notice it's right in front of the rectum, and this is the relationship we use to feel the back surface of the prostate, where most of the cancers arise. All right, can I have the next slide, please? Okay, so that's another view of the prostate and the seminal vesicles, where most of the semen arises from. The next slide, that's a view looking from the back. And then this is another view of the prostate, again looking at the bladder on top, the prostate below, and then you're seeing some important nerves in yellow. Those are nerves that you see going into the root of the penis, and those are the nerves that we try to spare. We go to a great deal to spare those nerves when we are removing the prostate, so that the men will continue to be able to enjoy erections having removed their prostate. Okay, so those nerves, we try to spare them at the time of surgery. The next slide. And then this is another view. This is another view looking from below. So this is the bladder here. This is the prostate. And this is a rectum. And again, you see the nerves going here, and these nerves are eventually going down into the penis. And those are the nerves that are important to be spared. The next slide. So we have told you about how we go about looking for cancer. But what is a cancer really, and why does it kill? Well, as you know, the body is made up of trillions of cells, and these cells arrange themselves in tissues, and tissues arrange themselves into organs, and organs arrange themselves into systems. And these cells that make up tissues exist in harmony with each other. The number of these cells are finely regulated by the nucleus of the cell and by interactions with other cells that they interact with. What happens is that when you have a change in the genetic makeup of the cell, or a change in the DNA of the cell, that causes dysregulated and abnormal growth of these cells, they produce a lot of excessive and abnormal cells, and these cells produce a mass or a growth. And when this what we call neoplasm acquires the ability to be able to metastasize or spread to distant sites in the body, then you have a cancer. And this cancer is a parasite because it diverts the body's nutrients to itself at the expense of the host. and it eventually grows and grows and grows, and it, depending on where it spreads to, it will also grow there, not only at the primary site, but at the site it has metastasized to, whether it's the liver or the lung or the brain, and eventually it will cause dysfunction of those organs, some of which are essential to life, or it may erode into a blood vessel and cause massive hemorrhage, internal hemorrhage, and so on. So these are some of the mechanisms by which a cancer will kill. But a cancer is a parasite, and it essentially will continue growing until the host actually dies. Next slide. So that just shows a group of cancer cells there, and as I said, it can spread to any part of the body. Next slide. So in Jamaica, we said prostate cancer is very common. It affects approximately 1 in every 10 Jamaican men, and the incidence is 78.1 per 100,000 men per year. And of course, the risk factors for prostate cancer, which we haven't spoken about yet, are age, race, and family history. And you'll recognize immediately that you can't do anything about any one of those three things. So you can't do anything about your age, you can't do anything about your race, and you can't do anything about your family history. So the three established risk factors for prostate cancer are what we call non-modifiable risk factors. So as men age, we know that the risk for prostate cancer increases, and it starts out at very low risk at age 40, but with each decade of life, the risk increases, and we recommend in our high-risk population that you begin screening at age 40. So I know a lot of ladies are here, so for those men who are not here, the ladies, I'm asking you to go back home and ensure that the men in your lives start screening at age 40. Because that's when the risk for prostate cancer starts increasing. We also know that prostate cancer runs in families. And remember, I said earlier, it's important to know your family history. So if you have a father or a brother with prostate cancer, you are twice as likely to develop prostate cancer than someone without that family history. If you have two brothers or a father and a brother, you're 5 times as likely to develop prostate cancer. And if you have 3 brothers or a father and 2 brothers, you are 11 times as likely to develop prostate cancer. So the number of first-degree relatives, and the younger they develop prostate cancer, the higher the risk of you developing prostate cancer. Having said that, the vast majority of prostate cancers are what we call sporadic, meaning that the majority of men, 90%, do not have a family history of prostate cancer. So not having a family history does not spare you by any stretch of the imagination. We know that if you have a family history, you are at increased risk. But the majority of men who are diagnosed with prostate cancer do not, in fact, have a family history. And then we know that prostate cancer runs or is at highest risk in men of African ancestry. And that is 94% of the Jamaican population. So if you are of African ancestry, you are at increased risk. One of the things that we now know to be true is that not only do men who have a family history of prostate cancer are at increased risk, but men with a family history of breast cancer. So if a man has a mother or a sister with breast cancer, that man is also at increased risk of developing prostate cancer. Because the same gene, the BRCA gene, the same gene that Angelina Jolie had that caused her to do prophylactic bilateral mastectomies, that same gene that causes breast cancer in women is one of the same genes that causes prostate cancer in men. So if a man has breast cancer running in his family, he is at increased risk of developing prostate cancer. So again, you see how important it is to know your family history. All right, the next slide. Next slide. Next slide. Next slide. Next slide. All of these things we have spoken about before. The next slide. Right, so we have mentioned that these are the foods that put you at increased risk of prostate cancer. The red meat, the animal fat, the dairy products, and the processed meats. Processed meats, not in this picture, but processed meats definitely puts you at increased risk. Next slide. Okay, so these are some of the things that put you at increased risk. Next slide. What are some of the things that prevent you from developing prostate cancer? So, green tea, soy products, tomato products, fatty fish, lots of different colored fruits and vegetables, vitamin D. Vitamin D is anti-proliferative, and the best source of vitamin D is the sunlight. Not the midday hot sun, but the early morning or late afternoon sun. Pomegranate, or what Jamaicans call pomegranate, or polyunsaturated fats that you get from nuts and avocado, what we call pear, and so on. So largely what we would say is a Mediterranean type diet is a good diet, because a diet rich in fish, nuts, fruits, tomato products, tomatoes. This is a kind of diet that will protect you not only from prostate cancer, but other cancers as well. Next slide. So these are some of the things that are good for you. The different colored fruits and vegetables, the nuts and the beans, the green tea, and the fish. Fish are the sardines, the tuna, the salmon, the mackerel. These are the type of fish that are good for you. Next slide. All right, I won't dwell too much on the clinical features of prostate cancer, because the whole point of this talk is to prevent it from occurring. And if it's one thing I want you to take away from today's talk, is that prevention is always better than cure. We don't want to be discovering men with prostate cancer because of symptoms, because as I said to you, when you have symptoms, it's usually too late. What I want you to remember is that once you get to the age of 40 and above, I want you to go to your doctor and get your prostate-specific antigen blood test done on an annual basis, and your rectal exam. That is how to prevent yourself from dying from prostate cancer, by early detection. And that goes for so many cancers. Colon cancer is the same thing. Early detection is what we want where colon cancer is concerned. We don't want you to wait until you're having the blood in the stool, or the alteration in your bowel habits, or symptoms of anemia. We want you to go to the doctor and have your colonoscopy done, or other screening tests once you get to the age of 45. Or if you have a family history and it's 10 years earlier than the age at which that person developed colon cancer, if it's earlier than the age of 45, we want you to be doing those things. All right, so I'm going to stop here, and I understand we have a panel discussion taking place. Fortunately, I haven't felt my phone vibrating, so I have not got any calls from the university hospital that I am needed, so I think I can stay with you for some time longer. Thank you.
Thank you, Dr. Akin. Excuse me a moment. Okay, we're going to have a little adjustment to the program. So before we have the panel discussion, so that we can facilitate if Dr. Akin needs to leave, if anyone has any questions for him at this time, we will take those questions. There is a mic in the middle right there if anybody has any questions. While you get your questions ready, I have one. Under the cancer prevention listing of foods that he gave, I found it interesting that tomatoes or tomato products were there, because I know growing up you used to hear, oh, as a man you mustn't eat tomatoes because the tomato or the tomato seed is going to do something with the prostate. So is it that that was just conjecture, or studies have no, because research and everything, things improve? Yeah, sure. Thank you.
Yeah, so there are a lot of myths out there regarding prostate cancer. And certainly what you just mentioned is one of those myths, because we know that tomatoes are actually good for you. The tomatoes are rich in a substance called lycopene, and lycopene is a bioflavonoid, which is an antioxidant, and it has multiple health benefits, not just for the prostate. So eating tomatoes or foods rich in tomatoes actually is good for you because of the bioflavonoid lycopene. There are many other myths out there regarding prostate cancer. What doesn't appear to be a myth and is based on scientific data, there's a study where they followed men over a long period of time and then looked at who developed prostate cancer and who didn't, and they compared the lifestyles of these men and looked back at their behaviors over a long period. And they found that men who ejaculated very often were less likely to develop prostate cancer than those men who did not. And so it appears as if one of the theories is that if there are any carcinogens or cancer-inducing agents in the semen, that men who do not ejaculate frequently enough, the carcinogen is in contact with the prostatic epithelial cells for a longer period, and then can induce a cancer-inducing effects more readily than for those men who ejaculate frequently. So one of the prescriptions that we give men to take home to their wives is to let them know that the doctor says that they should engage in regular sexual activity, because that decreases the risk of prostate cancer.
Duly noted.
Is the mic working?
Right, good evening again. Excellent presentation. I've learned so much. One question though, I noticed under the healthy foods that are to be consumed, there was soy. But then soy in itself may have, I'm not sure, you could tell me, but I think for especially Black people, then that's a challenge as well. So can you elaborate, is that something really healthy for people of our skin color?
It's not so much a skin color, it's the sex or the gender of the person. So soy, one of the reasons why soy decreases your risk of prostate cancer is that when you eat soy, it is metabolized to weakly estrogenic compounds. And these weakly estrogenic compounds decreases the risk of prostate cancer. In a female, however, especially a postmenopausal female, these weakly estrogenic compounds stimulate the inner lining of the uterus and will increase the risk of endometrial cancer. So years ago, there was a study done in nurses who were followed over many, many years. And they found that women or nurses who ate a lot of soy, that they were dying from endometrial cancer. So for women, especially postmenopausal women, soy is not such a good idea. But for men, there is nothing wrong with eating soy as long as it's done in moderation.
Just one quick question. I know in Jamaica they're always saying when men are very virile, that's a contributory factor. Is that a myth or is it a reality?
No, there's no scientific evidence that our so-called virility increases our risk of prostate cancer. We know that testosterone is necessary to develop prostate cancer. But there is no evidence that Jamaican men are more virile than men elsewhere, or that there is an association between our testosterone level and prostate cancer. Yeah.
Doc, I want to follow up on your logic in regard to ejaculation frequency. You mean like this? Okay. All right. How do you explain then the logic of celibate priests, the Roman Catholic priest, who chooses to be celibate from very early, that cohort? How would that logic follow from what you are saying now about, well, when that cohort has been tested, is it inconsistent with the rest of the population that you have described?
Sure. So I'm not sure that there is any study that has compared priests with persons in the population who have various frequencies of ejaculation. What I can say for sure is that this cohort of men who were followed over many years, it's called the Men's Professional Health Study, and you can Google it. They followed the men over many years and compared men who developed prostate cancer with men who didn't. And on average, men who developed prostate cancer, one of the differences between them and the men who didn't was their ejaculation frequency. And so in this fairly robust study over many years, it does appear that ejaculation frequency may play a role. Now, it could well be that there are confounding variables. It could be that men who ejaculate more frequently engage in other activities that might reduce the risk of prostate cancer. That's the thing with these observational studies. You can never necessarily control for every single confounding variable. But these prospective studies done where you follow people forward in time tend to be more robust than where you look backwards at persons and you know, based on the diseases that they have from the get-go, and then look at risk factors back in time. So it's a fairly robust study, but there may be other factors at play. You mentioned Roman Catholic priests. One of the groups in terms of religions that have the lowest incidence of prostate cancer are Seventh-day Adventists. And this is because we think of their diet. They have a diet that is very low in animal fat and red meat and so on. And, you know, we feel that their diet may play a role in why they have such a low incidence of prostate cancer.
Yeah, I just want to tweak. Right. I just want to tweak the question raised by Sister Carrie Ann a while ago. Not necessarily virility, but multi-partner relationships. I mean, I don't know if it's mythical or legitimate. There's a view that multi-partner relationships may contribute to the prostate cancer problem.
Yeah, so I can definitively say that that has been
Ruled out?
ruled out is not the word I want. It
Demythologized.
no. So we have done studies on that because yes, it was once felt that multiple sexual partners and exposure to different organisms such as human papilloma virus and other sexually transmitted infections may increase a man's risk of prostate cancer. And in the early days, there were retrospective studies that give you a lower level of evidence that suggested relationships between having gonorrhea and the development of prostate cancer and so on. But we actually did a study here in Jamaica, and we found no relationship between the number of sexual partners, the age at first coitus, and other sexual factors, and the development of prostate cancer. Also, there have been studies done that have specifically looked at germs such as human papilloma virus, some strains of which cause cervical cancer, as you know, and we have found no relationship with prostate cancer. So it does not appear that the evidence supports the number of sexual partners or the age at which a man first has sex or the exposure to sexually transmitted infections and the development of prostate cancer. When I started doing urology, that was something that was actively being investigated, but I think over the past 20 years, a lot of studies have come out and they have all pointed in the same direction, that it's not likely that there is a causative relationship between these factors and prostate cancer.
All right, thank you for your responses so far. You would have spoken about having foods like salmon, mackerel, sardine. Would you recommend being able to have them in the tin form, tin food? Is that okay?
Yeah, that's okay. It doesn't matter if they're in the tin or not. It's more the nature of the food. So fish, especially fatty fish, such as your sardines, your mackerel, and so on, are good, whether they're in the tin or not.
Okay, thank you.
Yeah.
Thank you, brother. Good evening, doctor.
Good evening, sir.
I don't really want this to be a testimonial, but I can concur and also say that I've experienced most of what you have described. There are a couple of questions I'd like to ask, though, when it comes to Jamaican men and taking this test, what I call a simple test. It's a phobia, but I think it's one that needs to be explained. But because I understand there's a historical fact behind it. In the times of when our foreparents were enslaved, producing sugar to send to Europe, to punish a field slave would be on a Sunday evening, have a gathering outside of the great house, under a big tree, a yard, whatever. And that slave would be buggered, is that buggery, whatever, by another slave. What's it called, buggery? Buggered by another slave. And that destroy mentally. Usually they'll kill themselves thereafter. So I think that's where that one is coming from. But I'd like to say to Jamaican men, please, it's a simple, simple process. Little finger about less than half an inch or inch into your rectum to feel whatever is there. Nothing else. Nothing to be ashamed of. Nothing to be afraid of. I did it, and it saved my life. My life. right? You mentioned earlier on, sir, pertaining to, touch the point exactly, but when you're in that situation, you're dying, you call out to God, you pray. But you know something, sir? You know, most of us, after God answer the prayer, we forget. We totally forget. And while you were there talking, I just reflecting on my experience. I've always wondered what it was like for a woman to have a child. That pain, oh God, I wish it not unto my worst enemy. It's a very expensive, it can be a very expensive operation. Because I remember when my doctor said, yes, you have prostate cancer. So I said, what's the options? And when you hear about $1 million, all words to that effect, it's not money you carry in your back pocket, but it's money you got to find. So all the time people say when trouble take you, picnic short fit you. It's that case. I'm a bit disappointed this evening somewhat to see so few men. So few men. I want to give honor and respect to the Jamaican women because my God, you're all great caregivers. Experience teaches me that. We talk about lifestyle. You have to exercise. It's as simple as that. You have to exercise. God give us limbs. If we don't move them, they deteriorate. We cannot function without muscles. And that muscle ignite the brain. It's simple science. We talk about what to eat. We can grow most of what we need. Who can plant a breadfruit tree? Who don't have a little plot and can plant a sweet potato? And what you don't have, you can go to the Coronation Market and buy it. Wonderful evening, sir. Wonderful evening.
Thank you, everyone. Okay, last one. Go ahead.
Good evening, Doc. Good evening. What I would like to find out is when the discovery was made. I remember as a boy growing up in the 60s, going into the 70s, I was really sorry for some of the older men in my community when they were suffering from what is known as stoppage of water, and nobody knew what was the cause. And so as a result, I would like to find out when was the discovery made. My father died in 1975, and to this day, we have not found out the cause of death. We have tried. We were told to go to the debt decks at KPH, and we have made several trips, and we didn't find out. But what we discovered that he had showed signs of cancer. Remember, he lost his hair and other signs of cancer. And he became ill, and we tried everything. But he died in 1975, and to this day, the cause of death is not known. But we suspect it was prostate cancer.
Okay, so remember I told you earlier that there are 3 diseases that affect the prostate, and I mentioned 2 of them. I mentioned prostate cancer, and I mentioned BPH. And I said that all men, as they get older, their prostates get larger. Not all men will necessarily develop symptoms. But I showed you the picture of the prostate, and I showed you the urine passage passing through the center of the prostate. So if that passage becomes narrowed because of enlargement of the prostate or because of cancer of the prostate, then the man will have stoppage of water. Now that stoppage of water can be acute or it can be chronic. If it's acute, the man will have sudden inability to pass urine that is associated with a lot of pain. And he will have to go to the hospital and have a catheter put in. And the underlying cause will have to be dealt with to get rid of the catheter. If it is chronic urinary retention, then that can affect your kidney function. And unfortunately, some men are discovered to have chronic retention, and when we look at them, they are in kidney failure because they have a situation where their bladder has not been emptying because the prostate is obstructing the passage, and more urine is being held in the bladder because the bladder stretches over time. The normal bladder can hold up to 800 mils of urine. If you put somebody to sleep and fill their bladder, can hold up to 800 mils. But in the chronic retention, your bladder can expand over time and can hold up to 2 liters of urine or more. But also, invariably, as the bladder expands, the effect on the kidney is that the urine made in the kidney is not moving efficiently to the bladder, and urine is backing right up. And so these people end up in kidney failure. And depending on how long it has been going on for, they can die from kidney failure, or they can die from infection, because you recognize that if you're not emptying your bladder well, there is stagnant urine in your bladder. And that is a lot of the men we see who have poor emptying of their bladder. It's infection that takes them out, or infection that causes them to come to the hospital, because that urine in the bladder is stagnant, it's stale. And if even one bacterium gets into that urine, within 20 minutes you have 2, and within another 20 minutes you have 4, and within another 20 minutes you have 8. So in no time you will have an infection, and that infection can rapidly spread to the bloodstream and cause septicemia and death. So a lot of men died as a result of that. So it has always been known that the prostate can enlarge and cause death, and as medical science has improved, we have been able to deal with this. But back in the day, a lot of men died from an enlarged prostate because they had a catheter put in, and they would live with the catheter for many years and not have it treated in an expeditious way to get rid of the catheter. And just having the catheter alone increases your risk of infection as well. So it's a double whammy. Whether you have the catheter or you don't have the catheter, until you can get it definitively dealt with, then the risk of infection is high. There are some men who, once we put the catheter in, for reasons based on their underlying health, they may not be able to tolerate an operation to deal with the underlying problem, and they may need to live with a catheter. And those persons are always at risk of increased infection. That's a risk once you have a catheter in. All right. So that's how a lot of those persons died, unfortunately, and still do die.
When was it that we have this scientific breakthrough? What year did we have it?
So, an enlargement of the prostate as we get older is something that has been known from the early 20th century. In fact, one of the treatments for prostate cancer occurred in 1944. Huggins and Hodges discovered that castrating men cause them to live longer if they develop prostate cancer. But from before that, it was known that there are 3 diseases that affect the prostate. So this would have been known from the early 20th century, the diseases that affect the prostate. The ability to treat them now has improved throughout the 20th century. And with the development of optical systems to allow you to do minimally invasive surgery. That would have increased the ability to perform surgical procedures on the prostate without having to cut people and allow you to operate on them through the penis and so on.
I'm going to just ask you for one question, Madam Chair. Doc, Prof, thank you so very much for your presentation so far. You spoke about the correlation of breast cancer, the gene, the breast cancer gene, and the correlation in the family history with our men and prostate cancer. One, in Jamaica, where are we now in terms of gene in mapping to have a repository as we look at moving healthcare in Jamaica, because gene therapy is here and very much being used. And so I just wanted to know, where are we? And that it is by no coincidence, but the Lord would have wanted it, because as the women and the men are here, we're both understanding the implications and the importance of knowing our family history. So just wanted to know, where are we, Jamaica, on the map with that, as far as we hear touted that healthcare is we're doing so well in healthcare. Where are we really?
So thank you for that question, Gita May. So there are entities at the University of the West Indies and private entities that can do genetic testing on different types of samples to determine the genetic profile of patients. So there's Carigen at the University of the West Indies, and there are some private entities that do genetic testing. So genetic testing is available in Jamaica. Sometimes the problem is the cost. So sometimes the cost can be prohibitive, but genetic testing is available. Importantly, it does allow us to risk stratify patients above and beyond just the usual things that we determine clinically, like grade and stage of cancer. The genetic testing gives us additional information on which to make decisions regarding the best type of treatment for patients. So it is available, but sometimes the cost is prohibitive. Yeah.
Thank you, everyone, for your engagement. And we are going to move on to our panel discussion section. Dr. Akin, you can stay at the table. And we will have our other panelists join him at this time. And just to give you a little information on them as they come, we have Bandel Sankofa, and he was born and raised here in Kingston, Jamaica, and did a degree in history with social sciences at the University of the West Indies. He has always had a deep love for history, and that would have sparked the degree that he did. And that love for history is particularly focused around the history of Africa, as well as the experiences of African people worldwide. He believes strongly in social justice for people who have faced oppression and human equity. In his spare time, he enjoys cooking, reading, listening to music, watching football, as well as movies. Our other panelist is our own Sister Carrie-Ann Davis, who is an international speaker and a certified mentor and coach, and has contributed to over a decade of quality service at the Department of Correctional Services in Jamaica. So, when we talk about knowing our numbers and knowing our health, it's not just about knowing the numbers on your PSA blood test and all of that, but we also need to look at our health from a mental perspective as well. So she has she's an associate counseling psychologist, and her greatest satisfaction comes from witnessing the character and behavior modifications of persons, and her motto is, "The time is always right to do what is right," quoting Dr. Martin Luther King Jr. She also has a YouTube vlog, Let's Talk Correction with Carrie-Ann Davis. So definitely check her out on YouTube to learn more. So our panelists are going to share. We've already heard from Dr. Akin, and after they have shared, we will have a little more time for some more questions.
Good evening, everyone. Thank you, Dr. Beecher. And thank you for inviting me, particularly Mr. Williams. When he asked me to come and speak, I said, but I'm a history man. What that has to do with science and all of that. But after listening, especially to what Doc presented very well, I just had to remember, and in fact, it is something I'm going to say. The past, present, and the future occupy the same time and space continuum. It may sound like something from Star Trek, I know, but if you think of it, we act the way we act because of what happened in the past, and the way we act and do things will affect the next generation, which is why I say it's all part of the same time and space. I promise you that my presentation will be not as long, but hopefully just as impactful, because I will be focusing essentially on some of the historical background to why is it we have the particular health issues that we do. And I wanted to start with something that one of the gentlemen raised, just to clear the air. He raised the question about, in the past, maybe part of the reason for men not wanting to do the prostate examination is because historically in the Caribbean, men were buggered by the slave master or by someone he ordered to carry out such a dastardly act. And I understand where he has gotten that from, because I see it quite a lot circulating on YouTube and, of course, TikTok and all the other platforms. So it is circulated quite commonly. Just to put some clarification, as far as we are historically aware, in the Caribbean, there is no evidence of such. The assertion has been made about it happening in the United States during slavery. I haven't personally read a lot on it, but based on what I have read on how slavery was conducted in the United States, it may be possible. It may be possible. But in the Caribbean, there is no historical evidence of it. So we have to be careful of the things that we see on our smartphone, on TikTok, Instagram, YouTube, and all the other sources. And just remember those two words put together, fact check. Try to do a little more reading so that we don't contribute to myth-making and mythology. All right, so my focus is the impact of slavery on the health of contemporary Jamaica. Yes, what does that have to do with what we are talking about today? Some of the very things that Doc raised, diabetes, hypertension, obesity, they have historical precedents. And let me start with a very sobering piece of information. As you know, the British took control of Jamaica in 1655. And as you know, Jamaica became a plantation economy. What do I mean by that? Jamaica became an important producer of export agricultural crops or their byproducts. So we're talking about sugar, molasses, rum, indigo, cotton, and some others I'm not remembering right now, with sugar being the most important. Well, here's this sobering bit of information. Between 1655 and 1807, when the slave trade ended, and when the British ended the slave trade, they didn't end it just for the British Empire. They were the international police of the world at the time, so they literally said, since we stop it, everybody have to stop it. So they confiscated ships from all the other countries that continued to carry on with their slave trade. But in that time period, 1.3 million enslaved Africans were brought into Jamaica. So between 1655 and 1807, 1.3 million enslaved Africans were imported into Jamaica. And yet, in 1834, when slavery was abolished, and as you know, we had a 4-year period of what was called apprenticeship. So you'll hear some sources say 1834, others say 1838. But the point is, when the census was done in 1834, for the African population in Jamaica, it was only 300,000 people. That meant our population was not growing throughout history. It's an indication of negative natural increase in the population. We had way less than who had come in. And why was this? There are a number of factors. One of them was called planters' policy. And planters' policy simply said, and by policy you won't find any paper or book written on it, it was simply an agreement among the sugar planters that it's better to import and work a slave to death and by the 3rd year replace him or her with another import. So that was called planters' policy. It was better to just work them to death rather than to keep them going and nurture them and let them reproduce and that sort of thing. They said it was cheaper. So that was one. There was the poor living conditions of the enslaved people. They lived in what were called the slave village or the slave quarters. And these quarters essentially were just huts, bare floor huts made of wattle and daub and thatch. Most times no blanket provided, most times no bed provided. So of course sleeping on the coal ground and of course exposed to the elements because the huts were not always well made. There was overwork. And as you know, working on the sugar plantation was no easy feat at all. We're talking about a work day that was easily 12 hours, and during crop time, when they had to cut the sugar cane and juice it and convert it into sugar, the working day extended to as much as 16 or even 18 hours, depending on the size of the plantation. So overwork was another significant factor that helped to explain why our population did not survive at the rate that it should have. Then, of course, there was punishment of all sorts, almost anything that you could think of that mankind can do to another wickedly. It was done during slavery to our ancestors. But the two main things I want to focus on are poor diet and disease. Poor diet and disease. Because some of the very things that we suffer from today, in particular the hypertension and the diabetes, have their roots in what our ancestors ate and what we have now come to accept as being part of the normal Jamaican diet, and we think nothing of it. So, during slavery, what was the typical diet? When it came to the meats, and by meats I include fish, they were either dried, salted, cured, or pickled meats and fish. So we're talking about what we commonly call saltfish or salted cod, mackerel, but if you think of the mackerel in the supermarket, in what form does it come? As pickled, or what we just simply call salt mackerel, right? We don't see it so much again in the supermarket. Shad, pigtail, salt beef, corned beef. And by corned beef, I don't mean what's in the tin. I'm talking about a slab of meat that has been salted and pickled. All right? Those were brought in by the planters because they were inexpensive, very, very cheap to purchase. And obviously, meats had to be preserved in that manner because there was no refrigeration until about the very late 19th century, early 20th century. So all meats, many meats had to be preserved in that manner. What else did our ancestors eat? Imported rice, cornmeal, and flour. Sounds familiar? And then, particularly in Jamaica, given the size of the country and the size of many plantations, so land was available and anything to cut costs was good. Almost every plantation had what was called the provision grounds. And that was the section where the enslaved population was given to grow their own food. So we're talking about yam, sweet potato, dasheen, cocoa, edos, banana, plantain. But you notice I hardly mention any fruits. Very little fruits. Fruit trees grew, of course. But as you know, fruit trees tend to take a very long time to grow and develop. And what the enslaved did was not so much to plant fruit trees, but to forage for fruits on the plantation. So they didn't get the amount of fruits that they needed. And then, of course, there was very little fresh meat or milk for our ancestors. And I'm going to come back to the issue of fresh meat and milk. But let me touch again on the salted meat. Why was that important that I mentioned all these salted fish and meats that our ancestors ate and that we continue to eat? And the whole process of curing these meats removed a lot of the relevant minerals and vitamins and the other essential nutrients that are in the meat. So yes, the meat was preserved and we're eating something, but it is not as nutritious as the fresh meat. And then of course, with many of it being salted, the usual method of cooking was to simply put and those of you who grew up in the country would know the term, to put the salt thing in the pot that is cooked along with the yam and the banana and the plantain and all the other things. And it's mixed with the cornmeal or the rice. So they ended up eating what was essentially a general stew with a little touch, the taste of meat. And the lucky ones would get a little piece of meat. But it was filling the belly, but not giving the body nutrition. So we have to bear that in mind in it helping us to understand today the role of hypertension or the salted things that we eat in our current society. And then, of course, the food that was provided for us, even when our ancestors grew the food, it was not at the relevant caloric level that was required for the very hard work that our ancestors had to do. I was reading earlier just to brush up on some of my information, and it said that most planters wrote in their journals that they provided all of these things for the Negroes who were very glad for it and that it provided the nutrients for them. But the historians and the scientists who work along with them said that these things did not give the caloric number was at maximum 3,000. And for the human body to grow properly, we actually need more than that. I think it's what, 4,000 or 4,500 minimum. So we were eating, but not being nourished. So it contributed to a low-calorie diet, deficient in vitamin A, B1, thiamine, niacin, and riboflavin. And then, what else caused our people to suffer in terms of food and therefore disease? War and hurricanes. When there were hurricanes, the ships from North America, Canada, and England could not make it to the Caribbean. And of course, during the 18th and 19th centuries, England was at war with almost everybody. Spain, France, Holland, the United States, and anybody that dared to challenge them. And part of England's policy was, once we declared war on a country, England did two things. They blockaded the enemy port, and they confiscated enemy ships. So when Americans, after independence in 1776, tried to continue the trade to the Caribbean of the cornmeal and the saltfish and the other things that the enslaved population depended on, they were prevented literally because the port of Boston and the port of Charlestown were blocked in by British ships. It may sound like, so what? Well, let me give you a little bit of information. During the American Revolution, which lasted from 1776 to 1783, an estimated 50,000 Africans starved to death in the British Caribbean. Because whereas in Jamaica, and even in Jamaica, there was suffering with that. But whereas in Jamaica, persons could at least grow some food. In the Lesser Antilles, sugar dominated the entire land. So there were no provision grounds. So they depended entirely on imported food from Barbados all the way up to Antigua. So 50,000 people in just that one revolution of our ancestors died because they could not get food during that one war. So, as a result of this poor diet, the overwork, the stress, and all the other things I mentioned, planters recorded, and their doctors, because there were quite a number of doctors, every plantation under law was required to hire a doctor to take care of the enslaved population. But as to how good those doctors were then was very questionable. In fact, a lot of the evidence seemed to indicate that sometimes just doing nothing was better than being seen by that plantation doctor. But they suffered quite a number of diseases. And a lot of these diseases relate to poor diet. Yaws, tetanus, night blindness, which they call sore eyes. There was another one called mal de stomac, or bad stomach. But what it ultimately resulted in, and the whites found this very strange, was that the people would be eating dirt, literally taking up dirt and eating it. And it was believed to be, it is now believed to be that for whatever reason, by eating the dirt, they were supplementing the minerals that the body required. But of course, it was not good for the body to be ingesting dirt. There are some modern doctors and historians looking over on the information who believe that the mal de stomac, or dirt eating, was a sign of beriberi, which we now know is associated particularly with rice eating, particularly in the Asian countries. And when I was reading over the information again, something that was very interesting was that the rice that was sent to the Caribbean was the dehusked rice. But a lot of the nutrients of the rice is in the husk. And of course, in cooking the rice, some of the husk will end up in it, so you'd still get some of the minerals. But if we're getting dehusked rice, we're just eating rice again, white rice on top of that. And as a result, again, filling the belly, but not much nutrition is being passed on. Another significant factor of death was simply infant mortality. Children did not survive. So there was neonatal tetanus, and just to end, I will point out one thing that one planter wrote, the West Indian literature offers many examples of mothers who had produced 15 children and lost all but 2, or who had born 10 children and yet has but 1 alive. So these were some of the factors in terms of the food that was given to our ancestors that caused the population not to grow until after emancipation. The population slowly started to grow, and it really wasn't until the 20th century that the Jamaican population turned over to 1 million people. If there are any questions in terms of what I have presented, I will hold it for the panel discussion and allow our next panelists to come forward. Thank you very much.
All right, so what a nice set of platforms from which to pivot tonight. I have a PowerPoint, and I'll try my best to go through as quickly as possible. First slide, well, we could go through, next, I'll tell you when, next. All right, let's stop right there. All right, so we have been talking, and I have a little quick activity for the men in the house and for the wives that are here. You're going to be representing your spouses. So if you have a smart device, I want you to turn on the camera and I want you to put it on selfie. So you're taking a picture of yourself. Let's do it real quickly. So I want you to look, who is doing it? Look in the mirror for the brothers. Do you recognize the man staring back at you? He has dreams. Next slide. But is he tired? He is strong, but sometimes silent. He loves deeply, but doesn't always know what to say. He carries pain in his body and his spirit, but keeps smiling through it. Some men are here tonight who have not even seen a doctor in years. Don't raise your hands. Not because you don't care, but because you have been taught to man up, push through the pain, ignore the struggle. Some of you men have no idea what your blood pressure is, or even what the PSA numbers mean. But I'm sure you know right now, because Prof did a fantabulous job. But deep down, do we really know whether or not something is off? Can you feel it in your bodies? Brothers, let me ask you, as you look into the camera, do you know what your blood pressure readings are? Do you know what your liver enzymes readings are? Do you know your prostate health? And finally, do you know your own stress levels, your triggers, or even the traumas? If you've answered no to any of those questions, you're in the right place. So, the man in the mirror, I want to sort of set a foundation. John 3:1, verses 2. Beloved, I wish above all things that you may prosper and be in good health. That's the biblical foundation that I want to set. There are some others on screen. As iron sharpens iron, so one man sharpens another. So the man in the mirror, we went through the questions. Next slide. I've got news for you. Keep it moving. Thank you. Good news. God has a plan for you. God wants you to have faith, but he also wants you to know your numbers. A lot of times, persons come to church and we over-spiritualize a lot of things. But God, who is tripartite, so it's God the Father, God the Son, God the Holy Spirit. Likewise, we have our physical bodies that we must take care of. And there's also the spiritual component to us that we must take care of. A lot of probably African American church, because we clap a lot and we dance a lot, we sort of get exercise in. But then there are some churches that are very quiet, and so there is not a lot of movement. And so we don't get exercise in. And for some people, that's the only time they move. But God wants us to be steward, not just over our wealth, but also our health. Next slide. So let's look quickly at the psychological connection, how knowing our numbers will affect our mental health and our emotional well-being. Now, there are 3 factors I want to look at: mind-body link, the cultural silence among men, and understanding our emotional well-being, or what the triggers are. So let's look at the mind and body link. High blood pressure, liver dysfunction, or undiagnosed other issues in the body can contribute to depression, irritability or fatigue, as well as anxiety. So if we think we could just pray these things away without the proper nutrition, without the proper health screenings, it means we're going to be compounding problems. So we are going to have health issues, and then we're going to become frustrated because it's going to bring on anxiety. Now, our second speaker spoke about the cultural silence among men. Many men in our Caribbean context tend to shy away from medical facilities. I don't know, our speaker spoke about on the plantation, persons never want to go get medical treatment, perhaps because of the sort of treatment that would be meted out to them, so they come up with their own remedies and sort of solve their own problems. So I don't know if that has continued in our context, in our culture, but it is important that we man up and get our screenings done, because if we don't do that, one, we're dishonoring God, because God indwells, and this is the temple. So we are supposed to be taking care of the temple. From a psychological standpoint, these internalized beliefs increase the risk of psychosomatic disorders, among other things. The third factor is mental health indicators. We need to know, just as how we check for the physical screenings or blood pressure, and among others, it is also important for us to know our emotional numbers. How often do you feel overwhelmed? Do I have frequent mood swings? Do I isolate myself from others? Do I have a sense of hopelessness or loneliness? Am I sleeping too much or too little? So every single thing that we do will always bring us back to center. Whether we are medical doctors, whether we are carpenters, whether we are psychologists, it will bring us back to the ultimate creator, because all knowledge really comes from him. A wise man is full of strength, and a man of knowledge enhances his might. That's what the scripture says. Knowing your numbers, then, is not a weakness. It is wisdom. It is strength under control. And of course, it is honoring the Creator. I love African proverbs. This one says, he who conceals his disease cannot expect to be cured. Knowing your numbers allow us to take action before a crisis.
Yes.
So what then is the role of the church and Christian psychologists? And I know persons will say, There's no need to qualify psychologists, whether you're Christian or not, but there is significance in that. The church ought to be a safe space for healing, both emotionally as well as spiritually for a person. We are supposed to be guiding persons on proper nutrition, proper health benefits from living healthier lifestyle, because God teaches that to us in His Word. Encourage persons to share testimony. Our brother shared earlier about how doing his own screening, how that has saved his life. And it is important for the older men to teach the younger men how to be sober. So once you're over 40, please go and get your screenings. Offer practical steps. We spoke about health screening. Go do your mental health check-ins as well. And again, check in with Bible support groups, whether men's fellowship, etc. Those can help to alleviate fears and pain as well. So, quickly, this is what I really want to get at. We have researchers who look at the stages of psychosocial development. In other words, from we're born up until the point when we die, we go through different stages of development. Keep it moving. I won't go through all of them. All right, so for young adults, that's where I want to start. Intimacy versus isolation, according to Erik Erikson. This is the age 20 to 40. So at this stage, we're seeing persons, so there's a struggle to connect or to retreat, or you find the individual men, they may carry wounds, so they hide behind work, they hide behind anger, or silence. Generally in Jamaica, people say men don't like to talk about their problems. And so when they do talk, it's usually in a violent way. So the end result can be explosive. And as a church, as a people, we don't want that to happen. But at this stage, it is easier to build strong children, it is said, than to repair broken men. But, our brothers, knowing your numbers is a way of choosing intimacy over isolation. When you check your blood pressure, when you show up for your tests and screenings, you are saying these three things. 1, I choose to live. I choose to love. And I choose to be present for the persons who need me. Very important. So we move on to the next stage for those persons 40 years old to 65, which is pretty much middle adulthood. And at this stage, according to Erikson, is generativity versus stagnation. So 1, this is the stage where you ask, am I making a difference? This is when illnesses creep in. So between 20 and 40, if we don't get it right, especially at that stage, it would have been nice to do it from childhood up. But yes, you can catch yourself at age 20 to 40. Do some exercise. Do meditation. Get involved in things that will cause you to become a better person, stronger. Eat better. You remember the slides from Prof's presentation with the multiple different vegetables and fruits and so on? Let's try that, because we might be saving our lives. 2, a good man leaves his inheritance for his children's children. 3, the inheritance isn't just about land and legacy and wealth and so on, but somebody must be able to say, it is within my family to eat healthy, to not have prostate cancer because we're checking early. How about we change the narrative? Once you're 40, we're calling up everybody on WhatsApp to say, have you done the prostate test as yet? Let's check in with our brothers. Let's check in with our spouses. Let's check in with the men around us, because sometimes if the wives, and this is where you come in, and the sisters and church family, encourage men to do this and go with them to show support. Give it to them as a birthday gift, an anniversary gift. Let's get this going. It's important. Keep it moving. So the final stage, which is later on in adulthood, is integrity versus despair. And that's 65 years old and above. At this final stage, we will reflect on this. Have I lived well, or have I wasted my days avoiding the tough truths? So at this stage, persons are coming down with all kinds of issues, including prostate cancer. But when you were 20 and 40 and coming up, we did nothing about it. But let's try and change that narrative tonight. He who conceals his disease cannot expect to be cured. It's a reason why I put that there again. To live with integrity in this stage means taking charge of what you can still control. Your health is your story. Let's change it. All right, this one you might not be able to see it, but I can share the slides in email afterwards. But what I want us to focus on is there are different things that happen to people at different stages of development. When most of the persons, I could safely say in here, except for probably Joel and a few others, are above 40. If I were to ask how many persons would have completed their prostate screening, I'm not going to ask, not embarrassing anybody, but I want you to think about it. What kind of legacy you're leaving your children if you will die at 50 because you had control to do something about your health, but you refuse? When your children could have you for another 30 years, or some people living all the way up to 100 years. What are we going to do about screening? Our mental health is just as important as our physical health. If we don't take care of our physical health, it means that we're going to ruin our mental health. They go hand in hand. Keep moving. I'm coming down. Keep going. So, call to action. Knowing your numbers is not just about living longer. It is about you living well. You are the temple, I said earlier, of the Holy Spirit. Know your physical numbers. Know your mental health signs. What are the signs of anxiety and depression and burnout? Know your spiritual state, your prayer life, the fellowship, servicing, coming to service, and participating. Take action. Talk about God. Trust God. He will heal you and give you wisdom to move. Where to get help? Meadowbrook United Church, of course. Come on out. We have our minister who is trained and can provide mental health support as well as other persons in the congregation. The numbers are on screen. The email address is there. Also, for persons who want to go a little deeper, there is the Jamaica Psychological Society, JAMPSych. The number is on screen. That's it, ladies and gentlemen.
Thank you very much to our panelists for those presentations. And Sister Kerry, you just answered my question, because I was going to ask, where can we go to get help if we need help? And that was on the slide, here at church or the JAMPSych. So anyone has any more questions, any for our additional panelists, or any lingering questions for Dr. Akin? Any more questions? Okay, I see no movement. So I just say thank you to our panelists and everyone who is here. At this time, I'm going to ask Sister Charmaine Murphy to come forward with our vote of thanks. And while she makes her way here, in the spirit of that we're talking about knowing our numbers, September is our anniversary month. And in the spirit of Meadowbrook United Church, helping us to know our numbers and to look at ourselves from both a spiritual and a physical health perspective, we will be having a health fair, and we will also be having a blood drive, which will be on the 6th of September. So all individuals between the ages of 17 and 60, and you will get more information as we go along, but please put that date in your calendar, September 6th, which will be our anniversary blood drive. So start eating up all the iron-rich foods, drinking up your beetroot juice, eat up your liver and everything. Although we spoke about the red meat and stuff, but Dr. Akin, I know we kind of need a little red meat to kind of build up the iron levels, right? To an extent, me. Okay, you can eat the dark green leafy vegetables, the callaloo, the pak choy, you know, and build up those iron levels so we can donate that blood, all right? Sister Charmaine. Okay, so we have Sister Pirette and Sister Charmaine.
Good evening or good night, everyone. I would just like for Professor William Akin, sorry, to take the stage from me, please. Dr. Akin, on behalf of the Meadowbrook United Church, we would just like to extend our deep appreciation for your expert advice, for your insight. I know many of us are leaving here tonight with so many questions. We're going to be doing our own individual research. I know for a fact that my husband is sweating right now because he knows the questions I'm going to be talking and asking in the car. But I think tonight was a very good night. Again, I am sorry that a lot of men were not able to make it, but I know that we also have good representation with the ladies who are always looking out for their men. So, on behalf of the Meadowbrook United family, again, we just want to say a huge thanks. I mean, this can't even compare to what it is that we've learned tonight, but we thank you nevertheless.
In the same vein, good afternoon, good evening, everybody. It's so good to see you. Mr. Sankofa, yes, sir. You have linked our past with our current reality, and we just want to recognize you properly. Come, please. Many of us, sir, have grown up hearing about the history, the legacy of history. And never we love the pigtail bad. But when you talk about the nutritional value of what we're eating, we have to think again. It's serious facts. And we thank you for sharing your space. Just that excitement that you bring about what you care about has made such a difference for us. It may be your first, but it's not your last time. Yes, we look forward to welcoming you back. And we really want to thank Brother Horace. He's the link man, yes, in all of this. Thank you, sir. Now, one of our own, you know, one of our own, and so deep she is. Come, Sister Davis, come. You did such a fabulous job of connecting all of the in-depth knowledge from the medical, because, I mean, Prof. Akin blew it out of the water, yeah? And Sankofa now linked the past, and now you come into, yes, the headspace, the physical, the spiritual. Sister, you got it. And I really appreciate the work you've put into it, because You're really helping us as a church family to move in another direction to connect the dots. And it's so important for us and the temple that we have to get it right. Thank you. So my brothers and sisters, I just want to say it wouldn't be an evening without you. You thought it important enough to be here. And we really want to recognize that. Dr. Akin, from the beginning, made himself available. And we appreciate, sir, that you recognize that you embody knowledge that we need. You share with such openness and simplicity that make it say that, yeah, you know, I can do this. And it makes such a difference. And we at Meadowbrook want to continue these kinds of conversations. Because I can tell you, we went out into a small group of us, went by Price Right, sharing, just trying to encourage persons to come. And I, pardon me with the Jamaican parlance, but these are young men in their 40s, yes, that age. And more than one said to me, that test that I have to do, no man go and put his finger there, not me. So how do you pass that barrier? Do you get somebody to write a reggae beat to get it to the rhythm that speaks to the mental capacity to recognize that a sort of thing go, if you love your life, this you have to do? But we have to understand that we all play a role. And life is life. And yes, God is God. So together, we share our talents and we share the space. And we just want to bless the persons who put their energies into this. You see, Horace, Brother Horace is the conceptualizer. He was passionate to get this done. Sister Perrette, where are you? Yes. So the two districts came together and yes, they approached me. But I want to tell you that, and I speak now from my dearly beloved husband's passing. He had a little thing about going to the doctor. So you older men, and us older women too, we just need to acknowledge that life is life and the decline is real. It's a new space. We have to own it. We have to work it because the wisdom that we have, no young mind has it. And that's why when Rev speaks and he says, recognize the gift that you are and God is in you. So own it, walk it, reach out with it, and impact lives. So with that said, we want to thank you all and invite you when we are all done to have a little refreshment. Thank you.
At this time, we're going to have the closing prayer, which will be done by Reverend Civile.
May I invite those who are able to stand to please do at this time. Let us give thanks. God of love, God of grace, We thank you for reminding us that knowledge is power. And that, God, when we know, you expect us to act. And we know that, Father, scriptures remind us that people perish because of lack of knowledge. But also having knowledge without having the commitment to use it becomes a challenge in itself. And that is where wisdom comes in. And we pray that you grant us the wisdom we require to be good stewards of our own bodies, and to know that the greatest gift we can give to ourselves is ourselves, and living well and making sure that we become as practical as we can be, and to ensure that we are responsive to that which needs to be done. We thank you, God, for those you inspired and empowered to bring us to this place, and for all those who took time to contribute to making this event what it is, and those, God, who have invested their time, their skills, and their expertise to make sure that we get and benefit the way we've benefited. We give you praise, O God, because all this is your doing. As we bring this session to a close, we thank you and we pray that you dismiss us with your blessings. Let the blessings of you, God the Father, the blessings of you, God the Son, the blessings of you, God the Holy Spirit, continue to rest, to remain and to abide with us all today and forevermore. Amen.
Have a blessed week, everyone, and definitely start working on knowing those numbers. All right, the doctor has spoken.